Welcome to your conference call entitled Prevention of Surgical Site Infections, a review of recent evidence and guidelines. My name is Jason, and I will be your operator for today's call. At this time, all participants are in a listen-only mode. Later, we will conduct a question-and-answer session. Please note that this conference is being recorded. I will now turn the call over to Peg Gilbert. Ms. Gilbert, you may begin.
Thank you, and welcome to our event today. We're excited about this opportunity to present new information on surgical and site infection prevention. This program is being brought to you by the Great Plains Quality Innovation Network Quality Improvement Organization, which serves North Dakota, Kansas, Nebraska, and South Dakota. And we're doing this in partnership with the Quinn QIOs that also serve a total of 14 different states. There will be a link to the handouts placed in the chat, and we will be monitoring that today if you have not received those already. So Dr. Bratzler has shared those with us. In addition, we will be answering questions at the end of the presentation. At this point in time, it is my honor to introduce Dr. Dale Bratzler. He's a professor in the Department of Health Administration and Policy and Associate Dean in the College of Public Health, and also a professor in the College of Medicine at the University of Oklahoma Health Sciences Center. He currently serves as the Chief Quality Officer also for Oklahoma University Physicians, and has recently assumed the role of Medical Director at the Clinical Skills Education and Testing Center at the University of Oklahoma. Those of us in the QIO community remember Dr. Bratzler from his time as the Medical Director and CEO of the Oklahoma Foundation for Medical Quality. And those of you that are involved in quality improvement remember his role in the SCIP measures of the Surgical Care Improvement Project. He has also been a recent member of the Healthcare Infection Control Practices Advisory Committee, commonly referred to as HICPAC. And that's where he has received the information that he's going to share with us today. So at this point in time, I'd like to welcome Dr. Bratzler and thank him for sharing his information with all of us today.
All right. Thank you, Peg, for the very kind introduction. It's really a pleasure to be here today. What I'm going to do over the next 45 minutes or so is review recent evidence and some of the guidelines that have been published on prevention of surgical site infections. And I hope to leave some time for questions at the end of my presentation. There are a few of the slides, I think you have handouts, but a few of the slides that I'll go through relatively quickly just to make a couple of points. And as I get to the end, we'll focus on those interventions known to help us prevent surgical infections. So I have no financial disclosures related to surgical site infection prevention to mention. And these are my objectives for the presentation today. I'm going to review updates and recent guidelines for best practices. I'm going to highlight some of the practical recommendations that have been developed for acute care hospitals, prioritizing surgical site infection prevention efforts. And then last, I really am going to focus on this concept of a multi-modal bundled approach to prevention of surgical infections, which I think is becoming somewhat the standard of care in the United States to reduce risk of infections. So, very briefly, if you read the Sheikh Compendium on prevention of surgical site infections, you'll see this information, but surgical site infections still remain far too common. They are the most common hospital-acquired infection that occurs in the United States, and when they occur, they create substantial morbidity and mortality for patients. Patients who die after surgery who have a surgical site infection, about 3/4 of the time the death can be directly attributed to the surgical site infection, and they're very, very costly to the U.S. healthcare system. I'm not going to spend a lot of time on this slide, but I think it's important to highlight that there are some things that we know about prevention of surgical infections and some things we don't know enough about. And just remember that there are many, many different factors that will create some additional risk for a patient to develop a surgical site infection. So things like host factors. many of which are not within our control. So we'll talk later. If you have a patient with diabetes, those patients clearly have a higher risk of surgical site infection. Obviously, emergency operations, sicker patients, greater risk. Some patients are colonized with bacteria, and we'll talk about some routine testing for some patients, but recognize that patients come into the hospital with bacteria that colonize their skin, and that could put them at increased risk. There certainly are different types of risk based on the type of operation. So as we'll highlight in just a moment, patients having colorectal surgery will have a much higher expected infection rate than a patient who's undergoing an elective knee replacement. And finally, there are those things that we could call exogenous factors, those that are related to the surgical team and hospital, and the things that we hope are within our control. So doing things like providing antimicrobial prophylaxis, screening for resistant organisms, controlling the operative environment and the number of people that are coming through the room, avoiding razors and other things. These are things that we can control, but they clearly contribute to the risk of a surgical site infection. So just very briefly, let's talk about a surgical incision. So this is not a particularly good picture, but it's a picture that suggests that in the operating room you have a surgical wound. Well, we know that there is no such thing as a sterile operating environment in the operating room. So bacteria actually do fall into the wound from the air, from ambient air, and of course we know that if you have more traffic through the operating room, it may increase the bacterial burden that's in the room. We know that certain types of operations substantially increase the risk of bacteria getting into the wound. So if you open the colon in the operating room, clearly there's a greater risk of contaminating the wound with bacteria. Believe it or not, surgical teams shed bacteria, and that's why Joint Commission and others are very critical if they walk in as a part of a site visit and see hair hanging out of a surgical mask or surgical attire. It's one of the reasons that we try to control the traffic in the operating room, because we know that the team itself will shed some bacteria. And then certainly more recently we know that anesthesiologists can contribute to surgical site infections. There is very good evidence that anesthesiologists going from room to room can transmit bacteria on their hands, and actually there have been very good studies showing that you can actually inject bacteria potentially even into IVs and other things and create surgical site infections. There's some very nice work that I've referenced on this slide. So, most of the time in the operating room, some bacteria get into the wound. It's almost impossible. You don't have a completely sterile environment. And yet, most patients don't get a surgical site infection. So, why is that? Well, certainly different operations have different inoculants. So again, we've already talked about a patient having colorectal surgery, a lot more bacteria and a greater risk of infection. There may be differences in surgical technique. It's been well demonstrated that different surgeons have different techniques, and even doing the same operation either on different patients or the same operation on similar patients will have greater risk of infection based on their actual surgical technique. And we also know that surgical wounds have varying degrees of severity. But the most important point I want to make is that most surgical site infections, most of them, start in the operating room when the wound is open. That's when the wound gets contaminated. You close bacteria in, and in a moment we'll highlight why it's difficult to prevent infection. Most patients don't get an infection. That's because host defenses take care of the bacteria that contaminate the wound. And again, we do certain things like providing preoperative antimicrobials. We try to control glucose because those things may actually reduce the risk that those contaminating bacteria actually result in a surgical site infection. So this is an important concept that most of the infections start in the operating room, and it will provide some of the background about why in the upcoming CDC guideline we recommend that you don't do things like continue antibiotics after you close the wound and other things, and I'll talk more about that. This was a nice study done by Stillman way back in the 1980s and basically showed that you can actually put bacteria, Staph aureus in this study, directly on top of the surgical wound. It depends on whether you closed it with staples or subcuticular sutures in this particular study. But beyond about an hour after the wound is closed, it was almost impossible to contaminate the wound or infect the wound with external bacteria because the wound itself closes over very, very quickly. So most infections start when the wound is open, or perhaps in that short period of time immediately after closure when the wound may be vulnerable. Finally, remember that once a surgical infection develops, it almost always requires drainage to take care of the infection. So once you've closed the wound, you basically have dead space. It's avascular because we've often bovied most of the places where there might be bleeding. It's hypoxic. The patient may be cold, and then you have this environment of interstitial fluid, glucose, blood, hemoglobin, and other things that promote bacterial growth. So you have a perfect place for bacteria to grow if they're going to grow at that point. And as I mentioned, oftentimes we do things like, bovie, using cautery to make the incision, and that can actually result in even less blood flow into the area of the wound. So that's why after surgery, if a patient develops a surgical site infection, the majority of time you have to open the wound and drain it because the antibiotics that you're going to try to give to treat the wound infection afterwards simply don't get there. So that's the background. And as I've already mentioned that the risk of a surgical site infection tends to vary substantially based on the operation being performed. This is data from NHSN from a few years ago, and again it highlighted that you would expect the risk of a surgical site infection to be greater for colorectal surgery than you would see with a hip prosthesis or elective knee surgery, where the risk of infection should be much, much lower. I will tell you that I believe these data that are reported to NHSN fairly grossly underestimate the risk of surgical site infection for a variety of reasons, and I'll just show you a couple of studies in colorectal surgery that highlight that. The first one is this study that was a study that was comparing the use of cefotetin to ertapenem, and I'm not going to go into that study at this point, but the point I wanted to make in this slide is that look at the rate of surgical site infections in this controlled clinical trial published in the New England Journal in some very good organizations. You can see that the risk of infection in those patients was around 25%. Similarly, here's a very recent study published in 2015, and again, this was out of Canada, and showing that the overall surgical site infection rates were 25% in this particular study. So again, the risk of infection following colorectal surgery is substantial, and I think that we often underreport any of the surgical infections that do occur. So I'm not going to get on that soapbox, but I am going to spend some time now talking about the development of national guidelines on prevention of surgical site infections. And I've had the distinct pleasure and the opportunity to work on 3 different guidelines now. The Multi-Specialty Society Guidelines on Selection of Antimicrobials for Surgical Site Infection Prevention, the Sheikh Compendium on Prevention of Surgical Infections, and finally, most recently, the HICPAC Guidelines that will hopefully be published in the very near future now. So the first guideline focused on antimicrobial selection. Which antibiotic should we give when a patient is having surgery to prevent a surgical site infection? This was a multi-specialty society guideline led by the American Society of Health System Pharmacists, the Society for Healthcare Epidemiology of America, Infectious Diseases Society, and the Surgical Infection Society. And this guideline focused principally on selection of antimicrobial prophylaxis. We did have a section called Common Principles, and I just want to highlight a few of the things that we mentioned in the guideline. First, antibiotics before surgery for almost any operation will reduce the risk of a surgical site infection. That doesn't mean we should give an antibiotic for every operation, because for some operations the risk of infection is so low, or the consequences of an infection are so trivial that it doesn't make sense to give an antibiotic for all operations. So It's important to remember, though, that there are studies in virtually every type of operation that has shown that if you give pre-incision antimicrobials, you can reduce the risk of a surgical site infection. Second key point that we made was that you should use the narrowest spectrum antimicrobial that is efficacious for the wound, the organisms that are most likely to cause a surgical site infection. You don't have to try to treat everything. We also explicitly recommended against routine use of vancomycin for prophylaxis, and in fact there are some recent studies that show that when you use vancomycin for surgical prophylaxis, you may increase the risk of kidney injury in some patients. So vancomycin should be limited to patients who are at risk for methicillin-resistant Staph aureus infection, who are known to be colonized, or in those patients who have a clear, well-documented beta-lactam allergy. Nobody knows exactly what you should do if a patient is colonized with some other multi-drug resistant organism. There simply are not good studies. Here's a study that I mentioned, fairly recent, from 2015 in orthopedic surgery, where they routinely were adding vancomycin to cefazolin for prophylaxis, and it resulted in an increased risk of acute kidney injury in those patients. So vancomycin is not a great antimicrobial for prophylaxis, particularly used alone, and it does have some risk. The one that we worry about the most, though, is development of resistance to vancomycin. However, sometimes it does make sense to give more than one antimicrobial. So this is a study we published a few years ago, looking at patients having coronary artery bypass surgery or hip or knee arthroplasty, primary procedures, not revisions. And we were surprised. This is data from the CDC's National Healthcare Safety Network, and we were surprised that nationally, when you look at reported surgical infections, 34%, fully a third of the infections that were reported were gram-negative. Well, if you had a patient that was thought to be at high risk of methicillin-resistant Staph aureus and used vancomycin for prophylaxis, you're not going to provide any protection for gram-negative organisms. So in our guideline on antimicrobial prophylaxis, one of the principles that we talk about is that particularly if you have surgical site infection surveillance data in your hospital that shows that you sometimes see gram-negative infections, to consider giving two agents, not one, anytime you have to use something like vancomycin for prophylaxis. So in most patients, if vancomycin was indicated because of methicillin-resistant Staph aureus risk, we would recommend that you add a dose of cefazolin to it. Or if the patient truly had a true beta-lactam allergy, you could use a dose of astrianan, gentamicin, or a single dose of a fluoroquinolone, but use something else to at least provide some gram-negative protection. Again, I'll highlight the guidelines, including choosing wisely. I love this recommendation from the American Academy of Allergy, Asthma, and Immunology that states explicitly, do not use or overuse non-beta-lactam antibiotics in patients with a history of penicillin allergy. And they go on to state in this Choosing Wisely document that while 10% of the population will come in and report that they're allergic to penicillin, studies show that 90% of the patients aren't allergic to penicillin. Those 90% of those patients are not allergic to penicillin. So take a careful history before you pull the trigger on using non-beta-lactams, because beta-lactams tend to be the best agents for surgical prophylaxis. I'll highlight, I'm not going to spend a lot of time on this, but in the Multi-Specialty Society Guidelines, we still recommended that antimicrobial prophylaxis be initiated within 60 minutes before the incision. If you're using one of the long half-life drugs like fluoroquinolones or vancomycin, you can start it within 120 minutes before the incision. There is no consensus that the entire antibiotic needs to be in the patient before the incision. You'd like to have enough in to exceed the minimum inhibitory concentration for the organisms likely to be contaminating the wound. For weight-based dosing, I have to tell you there's not a lot of good studies out there. There are observational studies that show that when you give larger doses of drugs such as cefazolin to obese patients, you can reduce the risk of a surgical site infection. So the only three antibiotics for which we could come up with relatively firm weight-based dosing guidelines was cefazolin at 25 milligrams per kilogram, gentamicin, single dose, 5 milligrams per kilogram, given once preoperatively with no postoperative dosing. And then similarly, vancomycin, 15 milligrams per kilogram is a minimum. Sometimes some cardiac programs are using 20 milligrams per kilogram minimum, one time before the incision with no redosing. How often should you reduce the antimicrobial? Well, only during the time that the operation is ongoing. So if you're going to reduce the antimicrobial in the operating room, you should do it at about 2 half-lives of the drug. So cefazolin, as an example, has a half-life of about 1.8 hours. So by the 4th hour, if you're still in the operating room and you gave a dose of cefazolin before the incision, you need to redose the patient in the operating room. We recommended in the Multi-Specialty Society Guidelines that all antimicrobials should be stopped within 24 hours for all operations, though I will tell you that if you read the footnotes in the tables, they suggest that single-dose pre-incision prophylaxis is probably adequate. And then we recommended against the use of topical antimicrobials. There are a few studies that suggest some benefit from some topical antimicrobials, but oftentimes those studies haven't done a good job of controlling for things like use of parenteral antibiotics. So if you give a big enough dose of the parenteral antibiotic before the incision, it doesn't appear that topical antimicrobials add much to well-dosed, appropriately dosed parenteral antimicrobials. In colorectal surgery, in the Multi-Specialty Society Guideline, we came out with a specific recommendation that if you're doing elective colorectal surgery, that you should give mechanical bowel prep combined with oral non-absorbable antibiotics, in addition to intravenous prophylaxis. Now, recent studies have questioned the value of the mechanical bowel prep, but there is increasingly strong evidence that oral antimicrobials do make a difference in patients undergoing colorectal surgery. So again, I want to highlight that we're not talking about skipping the parenteral antibiotic. We're talking about an oral antibiotic plus an IV dose, which reduces the risk of surgical site infection. And I think if you'll look at several of the studies that have been published, the reductions in infection rates are dramatic. They're very substantial. Here's a study from the VA by Cannon, and in this particular study, they correlated the use of oral antimicrobials with the risk of surgical site infections. Those facilities in the VA that used oral antimicrobials for elective colorectal surgery about 90% of the time had much lower rates of surgical site infection than VA facilities that did not routinely use oral antimicrobials. And this is a study from the Michigan group that basically showed that the risk of all surgical site infections was dramatically reduced from about 10% to 5% in patients who received the full bowel prep, which in this study included mechanical preparation and oral antibiotics. And most interestingly here, they also did not see any increased risk of C. difficile, and patients tended to have a shorter duration of their ileus postoperatively. What about pre-screening for Staph aureus colonization? Well, a couple of things we know for sure. If a patient is colonized with Staph aureus, they are much more likely to get a surgical site infection due to Staph aureus. And so in the guideline, we specifically recommended that particularly in orthopedic surgery and in cardiac surgery, where the most studies have been published, that you consider pre-screening the patient, and if the patient is positive for Staph aureus, that you decolonize the patient with something like mupirocin, or more recent studies have been using the povidone iodine, and that you, if the patient happened to be colonized with methicillin-resistant Staph aureus, add vancomycin to your surgical prophylaxis. There's a very nice study that was published just recently by Maren Schweitzer from Iowa, that looked at a bundled intervention in patients having cardiac hip and knee surgery. I had the pleasure of being on the technical panel for this particular study, and what they did was they looked at patients undergoing these orthopedic and cardiac surgeries, and they screened them preoperatively for Staph aureus colonization. Again, I'm saying Staph aureus, not MRSA, but both MSSA and MRSA. If the patient was methicillin-sensitive Staph aureus positive, the patients got chlorhexidine bathing and mupirocin nasal application for 5 days. and they got cefazolin for surgical prophylaxis. If the patient was MRSA positive, they still got chlorhexidine bathing, mupirocin nasal application, but they also then this time had vancomycin added to the prophylaxis because they had colonization with methicillin-resistant Staph aureus. And then if they were negative screens, they simply got the routine preoperative bath, either a preoperative bath or chlorhexidine, and cefazolin was used for prophylaxis. And the results of the study were quite significant. They demonstrated a fairly substantial reduction in the risk of surgical site infections in these patients. There was one spike you'll see in about July of 2014 when they were doing the study, in 2013. And that was actually when they had a marked increase in non-compliance with the protocol. And in fact, that was a problem. The risk of a complex Staph aureus surgical site infection decreased significantly after operations performed by surgeons who were compliant with the protocol. They broke the data out based on compliance, and if the surgical team was not compliant with the protocol, the risk of surgical site infections did not go down. So that is a quick review of the Multi-Specialty Society Guideline. Now I want to spend just a few moments talking about the HICPAC Guideline. I'm happy to report that as of this week, it is actually in the CDC clearance process, which is the final step before publication, so hopefully it will be out in the near future. This was a guideline that has taken us 5 years to write. It's very complex writing CDC guidelines. Had a core writing group with HICPAC leads. We used the University of Pennsylvania Center for Evidence-Based Practice to do all of our literature reviews. And then we had technical input from many, many different specialty societies and experts nationally in surgical infection prevention. We reviewed a lot of articles. We started off by reviewing somewhere around 5,200 studies that we did full title and abstract review. A lot of studies were excluded because they were not controlled. Subsequently, I'll just go to the bottom of the slide and highlight that there were only 133 studies that had high-quality evidence in the core section and arthroplasty section of the guideline. We did do a second literature review, though, because it was taking so long to do the guideline. We identified another 500 abstracts. Two of us went through all of those texts, and we found another 62 articles that were high-quality, randomized controlled trials that we could use to supplement the guideline. So let me just give you a quick overview of what the guideline will say. So we did do a very detailed analysis of all of the studies. One thing I will highlight is that we looked carefully at meta-analyses. We found all sorts of problems with meta-analyses because although the meta-analyses may have been done technically correctly, when we looked at the individual studies that were in the meta-analyses, we often found evidence that the studies that were included did not include standard practices related to prevention of surgical site infection. So we had to look at all the meta-analyses very, very carefully before we included them in the guideline. The recommendations will come out with this methodology. So Category 1A recommendation is always strongly recommended. Well-designed experimental clinical epidemiologic studies. Category 1B is strongly recommended, but the quality of evidence is less. Category 2 is poor, low-quality evidence. You might do it, although there's no strong evidence, and then, sadly, for surgical infection prevention, there are many unresolved issues. These are the key topics that we addressed in the guideline. We focused on a core section that focused on antimicrobial prophylaxis. We did not look at selection, which was covered in the Multi-Specialty Society Guideline. We looked at glycemic control, keeping patients warm, giving supplemental oxygen, and skin preparation. In the arthroplasty section, we looked at these topics: transfusion, immunosuppressive therapy, anticoagulation, use of the orthopedic exhaust with space suits that you see used, antimicrobial prophylaxis duration with drains, and biofilm. So let me just summarize some of the key findings. So, Category 1B recommendation to always administer a preoperative antimicrobial agent when indicated based on published Clinical Practice Guidelines and timed such that you have a bactericidal concentration of the agent in the serum and tissues when the incision is made. Again, it doesn't say you have to have the entire dose in. You just want enough in to exceed the MIC, the organisms likely to cause an infection. For cesarean section, however, we found high-quality evidence, randomized controlled trials, clearly showing reductions in rates of infections by giving the antimicrobial agent before the skin incision and not waiting the way we used to until the umbilical cord had been clamped. So for Category 1A recommendation, give the antimicrobial before incision in cesarean section. We could not make any recommendations based on weight adjustment of dosing or intraoperative redosing of patients. The reason we gave this a no recommendation is because there are no published randomized controlled trials. If you look at the guideline, it will highlight that other guidelines do recommend that you weight adjust dosing and give intraoperative redosing, which are based on observational studies, but there were no published randomized controlled trials. But here's one where there are many randomized controlled trials. We found more than almost 50 randomized controlled trials in clean and clean contaminated procedures that there's no benefit of giving antibiotics after you close the incision. So we do give that a Category 1A recommendation to stop the antibiotics when you close the incision. Give preoperative doses. If you need to, redose in the operating room, but once the wound is closed, you're not going to reduce the risk of surgical infection with additional antimicrobial doses. What about blood sugar control? There's been a lot on this topic recently. We do give a strong Category 1A recommendation to controlling blood sugars. We had lots of discussion about the best target blood sugar. We settled on 200 milligrams per deciliter. I will tell you that some studies use lower numbers, but there's not good consensus on what the target should be. But certainly we don't want patients postoperatively having blood sugars of 300 or 400. So we targeted keeping the postoperative blood sugars less than 200 milligrams per deciliter. Again, some studies would suggest that maybe 180 or 140 is a better target, but those are observational studies and we couldn't make any firm recommendation. There's a very nice meta-analysis just published by Emily Martin and a group out of Michigan, Keith Kay's group, that looked at diabetes and the risk of surgical site infections, a systematic review. There's also a nice review of this paper published in Medscape, if you go online in Medscape and look for this study. And basically, just having a diagnosis of diabetes substantially increased the risk of a surgical site infection. Looking at cardiac surgery doubled the risk, but for most other operations, gynecologic surgery, 60% increased risk of infection, spinal surgery, 60% increase. So very consistent. Many of these studies find an increased risk of surgical site infections based on the diagnosis of diabetes. And of course, as you'll see in that Medscape article, Pat Dellinger did a nice job. It's probably the blood sugar, the diagnosis of diabetes is a marker for patients who have hyperglycemia. What about keeping patients warm in the operating room? We gave this a Category 1A recommendation. We don't know the best strategy to keep patients warm because there aren't good randomized trials. We don't know how long you should do it, but certainly while the patient's in the operating room, we gave a Category 1A recommendation to keep the patient warm in the operating room. I think the American Society of Anesthesiology targets a temperature of at least 35.5. Oxygenation, this one's a bit more complex. There are studies that show, randomized trials, that show that giving supplemental oxygen to patients after surgery, either during the operation and after surgery, can reduce the risk of surgical infection. But you have to look at those studies carefully. Most of those studies were in patients who had general anesthesia and endotracheal intubation. So what we basically say in the guideline is that if you have a patient with normal pulmonary function undergoing general anesthesia, endotracheal intubation, then administer increased inspired oxygen concentration both intraoperatively and post-extubation. Most of the studies that have been published used 80% oxygen in the OR and postoperatively. I will highlight that no studies have looked at 50% or others, so we could not say in the guideline about what the best target was, what FiO2 you should always use, and how long you should do it postoperatively. When you look at the studies, most of them used 80%, and they often kept them on oxygen for at least 2 hours postoperatively. What about antiseptic prophylaxis? This has been a bit controversial because it's not consistent with some of the bundles that have been promoted around the nation. But basically, we give a Category 1B recommendation to advise patients to shower or bathe with either soap, antimicrobial or non-antimicrobial, or antiseptic agent on at least the night before the operative day. We actually did not find good randomized controlled trial evidence that use of certain agents like chlorhexidine or others was any better than just using soap for preoperative bathing. So I know there are bundles out there that promote the use of chlorhexidine and other agents, and that's fine. I don't think it harms anything, but we just simply didn't find any evidence that that was better than soap. What about intraoperative skin preparation? We give a Category 1A, again, a strong recommendation to use some agent that has alcohol in it. There are studies that show no difference in infection rates when you use an iodine prep that has alcohol in it compared to chlorhexidine alcohol. So the guideline will give a 1A recommendation to use some alcohol-containing preoperative skin prep. Now remember, you can't use alcohol in all patients, particularly if you're operating close to hair, because you can't get the alcohol dry, and there is a fire risk when you use an alcohol-based skin prep. We did not find very good evidence about the use of these antimicrobial sealants. Following intraoperative skin prep, these sealants that you put on the skin to try to glue down the bacteria so they don't move. Not much good evidence there. And there was a little bit of evidence on intraoperative irrigation of deep or subcutaneous tissues with aqueous iodophor solution, but that was limited primarily to the abdominal wound after surgery or spinal surgery, but not the intraperitoneal cavity, and for dirty and contaminated operations it didn't seem to be beneficial. So a very weak recommendation there also. Well, there are all sorts of things in the guideline that are going to come out as no recommendation or as unresolved issues. They include things like what's the best weight-based antimicrobial dosing regimen, intraoperative redosing, irrigation. What about soaking prosthetic devices before you put them in the patient? What's the value of the hemoglobin A1C? And every single one of the orthopedic key questions that we looked at, there was no good either randomized trials, and we also looked at observational studies and didn't find strong evidence for any of the practices. The only orthopedic practice for which we found strong evidence for was to stop the antibiotics when you close the wound. I'm going to get to this one controversy just very briefly, and that was about should you use these antimicrobial coated sutures. The most common agent is triclosan. And I will tell you that it's been quite controversial. So when we first wrote the guideline in July of 2013, it gave a Category 1A recommendation to not use sutures. We then subsequently, by December 2014, said 1A recommendation to use them for colorectal surgery. And then finally in the HICPAC meeting, the final recommendation was, at that time, in mid-2015, was use of triclosan-coated sutures if they're available in a Category 1A recommendation. However, I will tell you, first, there's very good evidence that sutures get contaminated and colonized with bacteria. This was a very nice study published in Surgical Infections in 2009. A morbidly obese patient who had surgery, emergency operation, had persistently draining sinuses 16 months after surgery. They tried multiple things. Finally, they reopened the wound, and sure enough, non-absorbable sutures had been used during the operation, and when they looked at them under electron microscopy or confocal microscopy, they found within the the suture itself, it was braided suture, they found colonized, teeming with bacteria. So clearly sutures can become colonized with bacteria. The problem was that when we looked at the quality of the studies on triclosan-coated sutures, many of those studies, again, did not control for other things that most of us would consider standard of care for prevention of surgical site infections. And I have to say that the committee was most influenced by a very well-done study that came out of Europe that controlled everything, including skin prep, prophylaxis with antimicrobials. They actually made them send in the suture packets. They used the same type of suture, both monofilaments on both the control arm and the coated arm, and they found no difference in surgical site infection rate. So we gave a Category 2 recommendation, a weak recommendation, to consider using triclosan-coated sutures for the prevention of surgical site infection. I think we did not find any studies that showed any harm in using them, but in the better done studies, the more well-controlled studies that were published, we just didn't find a huge benefit to using them. Well, let me end with just a couple of comments about the bundled approach to prevention of surgical site infections. I think there's growing consensus that, well, as many of you probably are aware, one intervention to prevent surgical site infections isn't going to reduce your rates. Just giving antimicrobial prophylaxis is helpful, but not enough. So a few years ago, we did a study and published it in 2005 looking at a bundled approach that included antimicrobial agent selection, appropriate timing and duration, keeping the patients warm, giving oxygen, keeping their blood sugar controlled, and doing appropriate hair removal. And in that study, we saw about a 27% reduction in the risk of surgical site infection. There have been other studies that have been published. One of the better ones that was published in 2013 was, again, out of the Michigan group. And they developed a nice bundled intervention to reduce surgical site infections. And they had 6 interventions that they looked at, and they included appropriate antibiotic selection, keeping the patient warm, giving an oral antibiotic with mechanical bowel prep for elective bowel surgery, keeping the blood sugar, they targeted 140 milligrams per deciliter, minimally invasive surgery whenever feasible, and keeping the operative duration short. As you know, the longer the operation, the greater the risk of a surgical site infection. So these were the 6 interventions as a part of their bundle, and what they showed was that if you did all 6 things, the risk in colorectal surgery of a surgical site infection was only 2%, incredibly low rate. But if you were only able to do one thing as a part of the bundle, the infection rate was 17.5%. So this was one of the better designed observational studies that looked at a bundled approach to surgical site infections. Well, let me end by just mentioning the Sheikh Compendium. I haven't talked about it a lot. There's one big difference between the Sheikh Compendium and the HICPAC Guidelines. The Sheikh Compendium will have more recommendations, and that's because the Sheikh Compendium was not limited to randomized controlled trials as the HICPAC guideline was. The Sheikh Compendium looked at both observational studies, and we also then, where there were not good studies, had to provide expert opinion when possible. So you'll simply see additional recommendations in the Sheikh Compendium on strategies to prevent surgical site infections. It was just updated in 2014, and I strongly encourage you to take a look at it as you're thinking about what bundled approaches you might take in your facility to reduce the risk of surgical site infection. So let me end by simply saying that surgical site infections are the most frequent healthcare-associated, particularly hospital-associated infection reported in the United States. I actually think the risk and the rate of surgical site infections is considerably higher than we see reported in NHSN. Certainly the risk varies by the operative type, and remember there are many, many different factors, including host factors that may or may not be within your control that contribute to the risk of surgical site infections. And finally, no single intervention is going to be sufficient to prevent surgical site infections. It's probably going to take multifaceted interventions, and the bundled approach is getting strong evidence now for prevention of surgical site infections. So, Peg, I'll stop at this point and take any questions.
Thank you. We will now begin the question and answer session. If you have a question, please press star, then 1 on your touch-tone phone. If you wish to be removed from the queue, please press the pound sign or the hash key. If you are using a speakerphone, you may need to pick up the handset first before pressing the numbers. Once again, if you have a question, please press star, then 1 on your touch-tone phone. So, just real quickly today, I just saw one in the chat room, a question go by about blood loss. Not great studies looking at redosing based on blood loss, but I think it's common practice. And again, for the most part, when you're using short half-life antibiotics like cefazolin, they're very safe. So if you have a patient that has substantial blood loss during the operation, then redosing with antimicrobials is probably acceptable and poses little risk to the patient for most antibiotics. Thank you. We have a question from Megan Cyphers from Dormont Vale. Megan, your line is open.
Oh, that's me. It's Joanne Harris. We have a ongoing question about when you're giving prophylactic antibiotics, and I know you mentioned it in your talk, and when you can actually do the incision. And when do you say that there's an appropriate tissue level of antibiotics? And we come across this more with our vancomycin in, quote, penicillin allergic, unquote, patients than we do with cefazolin because it is a longer administration time. But, you know, what is your opinion about the duration of administration of the antibiotic prior to the incision?
Yeah, so that's a great question, one that comes up very, very frequently. So I'll highlight, so with drugs such as cefazolin, as you mentioned, you can get those in quickly. In fact, some facilities actually give it IV push. You can get it in 3 to 5 minutes IV push if you want to really get it in. So you can do that very quickly. Drugs such as vancomycin that have, you know, where your infusion time is going to be longer, how much needs to be in before you do the incision? And there's no good studies published. The best study I've seen was from a number of years ago in cardiac surgery, and what they demonstrated in that particular study that the infection rate, the surgical site infection rate, was lowest in that study when the vancomycin was started in the time frame between 15 minutes and 60 minutes before the incision. Many of the patients not having complete infusions at the time of the incision. There's no consensus among the experts that the entire dose has to be in the patient when you make the incision, and as the surgeons tell me, they're convinced that the risk of wound contamination and wound infection is not linear, and in fact, at the start of the operation, when you're first making the incision, it's usually very vascular. The wound's not cold. You have good blood flow, and the risk of infection may be lower at the first part of the operation than if you contaminate the wound with bacteria at the end of the operation. When now you've got, you know, decreased blood flow, oftentimes hypoxia of the wound, and other things that may reduce the ability to fight off infection. So I can only tell you there's no great studies, but the best one I've seen showed that vancomycin started anywhere from 15 minutes to 60 minutes before incision actually reduced the infection rates more than getting them earlier. You know, I think get some in, but many of the surgeons that I work with on this project are certainly comfortable as long as the antimicrobial is running when the incision is made.
Thank you.
And once again, if you have a question, please press star, then 1. Our next question comes from John Hitt from Hennepin County Medical. John, your line is open.
Hi, Dale. John Hitt. Any evidence at all dealing with the influence that residents and teaching programs might have on surgical infections? You know, we struggle with understanding the importance of attending presence, surgical length of time, and adequacy of teaching.
Yeah, John, so it's good to hear your voice. It's been a while since we've talked. So I can't quote any studies right offhand. I think there are a couple things we know about surgical site infection. So the longer the duration of the operation, the greater the risk of the surgical site infection. And I think oftentimes in teaching programs, that's one of the things that you see is that the duration of the operation is longer. Oftentimes also in academic centers or where there's teaching, you'll have more traffic through the operating room, more people in the room, and that seems to be potentially a risk factor for increasing the risk of a surgical site infection. There are some great studies. There was a very nice one in the New England Journal of Medicine looking at surgical technique and just demonstrating that you can, just if you watch surgeons or watch, videotape surgeons, that some are very good at tissue handling and very delicate in the operation, and some are not particularly adept at it, and that probably has some influence on rates of surgical site infection. And then finally, there are a number of observational studies that show that, believe it or not, some surgeons have higher infection rates than others that don't seem to go away when you risk adjust for the severity of illness of the patient or the type of operation that's being performed. So I think house staff training that are learning doing surgery, the surgery may be longer. They may not have some of the skill and the technique and the tissue handling that may be very important in reducing wound injury to the tissues that may result in higher rates of infection. There may be more blood loss or other things. So I can't quote specific studies, but I think there's a lot of reasons to think that if you're in a teaching program, potentially, there may be some greater risk of surgical site infection if there are more people in the room or less skilled hands doing the operation.
Thank you. And we have no further questions in the queue.
So I see one question in the chat room about patient temperature. What's the recommendation for minimum patient temperature? I believe the American Society of Anesthesiology has targeted keeping the patient temperature at least 35.5 degrees centigrade. There is no recommendation about the room temperature. I know that's talked about often. It turns out that most of the heat loss that occurs in the operating room is not because of the room temperature. And so some of the surgeons say, you don't want me sweating and dripping into the wound. Yes, many times operating rooms are kept cooler because the surgeons are in, lead gowns or, drapes, in gowns and other things that will keep them warmer. But there's not a huge amount of evidence on the risk of surgical site infection specifically related to the operative room temperature. That may not be true in kids or infants where they may be more susceptible to environmental cooling. The big thing is whatever technique you use, whether you're using things like Airhuggers or mattresses on the operating table or warming fluids or other things to target keeping the patient warm in the operating room. And 35.5, I believe, is the target that the ASA set as the minimum.
Dr. Gratzler, there are also questions further up. I'll read them to you. Despite implementation of surgical bundles, we continue to see colon SSIs without any apparent commonalities. Do you have any suggestions?
Well, of course, it's a little difficult to know exactly what's going on. I mean, the bundled approach, I think, is very, very important. I would ask, remember the study by Marin Schweitzer that demonstrated that bundle compliance is also very, very important. Just because you've implemented the bundle, are they actually implementing all the aspects of the bundle? For colorectal surgery, I strongly recommend the use of oral antimicrobials, non-absorbable antimicrobials, in addition to weight-based preoperative and dosing of the antimicrobials. So one of the common things we see is that antimicrobials are underdosed pre-incision. And then if the operation is relatively long, remember some of the antimicrobials that are being used have very short half-lives. So particularly if you're using any of the penicillins, they have very, very short half-life. Cefazoline's only about 1.8 hours. And so, I would be liberal with redosing in the operating room. I would also look at your surgical site infection surveillance and see what organisms are causing infection, because maybe you need to adjust your antimicrobials based on the types of infections that you're seeing. I would not continue antibiotics post-wound closure, because that hasn't been shown to help, and it may just drive resistance. But really focus on the things that have been shown up front to make the biggest difference. And consider oxygenation. I don't know if your anesthesiologists have taken that on, but consider hyperoxygen as an additional approach. And the other one that we found in the Michigan study, one of the things that was commonly not done well was glucose control. I think it's very important. Hyperglycemia perioperatively and particularly postoperatively seems to increase rates of surgical site infections.
Thank you. I think we have time for a couple more questions. Another is, what is the role of wound vacs for prevention of surgical site infections? Our surgeons are placing over closed incisions.
Yeah, I honestly don't know that I've ever seen a study that, truly compared rates of surgical site infections with or without wound vacs. I've mentioned before that certainly if you had somebody that was oozing, had blood in the wound and other things, definitely increased the risk of surgical site infection. So in that circumstance, you could see that it might be useful, but I haven't seen good randomized trials that show that it has a big difference, and it was not one of the questions that we addressed in any of the 3 guidelines.
Thank you. Another question. What is the role of transparent dressings left in place over incisions for days without changing?
Well, actually, there are some very nice Cochrane reviews on dressings showing that it almost doesn't matter what you use. Again, remember that the reason I showed that slide, that old slide, 1980 by Stillman, was that once you've closed the wound actually closes over itself fairly rapidly. So most of the time we put dressings on primarily to protect the wound from abrasion or other things that might injure and potentially reopen the wound. But in the Cochrane analysis, they found no difference in infection rates based on any type of dressing that you used, whether it was antimicrobial, silver, plain, and their recommendation was to use the least expensive that you could find. I just don't know of any strong rationale to pick one dressing over another. I think in large part, surgeon preference. But the wound itself, in most patients, closes up very quickly.
What is your perspective on probiotics taken before colorectal surgery, a week to a month prior?
We actually talked about that a little bit, but we did not find any studies that show any reduction in risk of surgical site infection. I know some people are using probiotics primarily to reduce the risk of C. difficile infections. That's why I highlighted in the Michigan Bundled Approach study, they looked at mechanical bowel prep along with oral non-absorbable antibiotics, because one of the complications that we're worried about was, if we wipe out bowel flora, are we going to increase C. difficile rates? And they actually did not do so. In fact, C. difficile rates were a little bit lower in that study because, perhaps in part because one of the non-absorbables that they used the most was metronidazole. I'm not aware of any good studies with probiotics that show that it reduces risk of surgical site infection.
What are your thoughts of Airhuggers contaminating the incision by disrupting the positive airflow in the room? I've heard a recent court case that referenced the Airhuggers.
Yeah, so that's been a popular topic, in part promoted by a company that sells a competing product, and there is no evidence that I'm aware of that shows that Airhuggers increase risk of surgical site infections. Remember, most wounds get contaminated. If you go in and culture wounds in your operating room, you'll find bacteria. Most of them get contaminated. But most of the studies with these forced warm air devices like Airhuggers actually show reductions in surgical site infections because you're keeping the patient warm.
Very good, thank you. We are past 3 o'clock. I'm wondering if you'd like to field more questions, or shall we wrap, and I can forward them on to you and let them serve.
That's completely up to you, Jean, whatever you guys want to do.
All right. Well, let's do a couple more questions. What is your thought on using a closing tray in Class 2 or higher surgeries?
Yeah, so it's been a while, but I did look at a study that looked at using a closing tray. Now, the concept here is to use a set of instruments that have not been contaminated during the operation itself, completely separate, sterile tray for the closure. And I honestly, it's been a while since I read it. I don't think that particular study showed a marked reduction or substantial reduction in surgical site infection rates, but I understand the rationale to not use instruments for closure that have already potentially been contaminated, particularly in colorectal surgery where you may be getting into the bowel. So I'd have to go back and do some research on that topic. I've seen a couple of papers on it, and none stand out in my mind that showed any dramatic reductions in surgical site infection rates, but I understand the rationale for at least studying the question.
Okay, our final question. I would like to know if CHG 0.5% as an irrigant versus saline or antibiotic irrigant prior to closing. And that's not a complete sentence.
Yes, but so in general, we did not find evidence of use of topical antimicrobials or antiseptics made a huge difference. Again, there was a little bit of evidence on using povidone iodine in abdominal wounds, not in the cavity, not intraperitoneal, but in the wound itself, or in spine surgery might reduce it. I actually had this question posed by a hospital not long ago, and again I highlighted that frankly irrigation is good to wash out bacteria and any debris left in the wound, hemoglobin, blood, or anything else. And sterile saline is probably about as good. So in the guideline, you'll see that we explicitly recommend against the use of topical antimicrobials, and we give very, very weak evidence, and only on povidone iodine for the irrigation of a wound. And frankly, I don't remember that we saw any randomized trials with chlorhexidine in irrigation solution. I don't know that there have been any studies.
This is Peg, and I think we need to say thank you very much to Dr. Bratzler for the information and explaining the difference in the guidelines, and look forward to seeing the new one as it is released.
Thank you, ladies and gentlemen. This concludes today's conference. Thank you for participating. You may now disconnect. Speakers, please stand by for your post-conference.